thanks once again to the organisers of this meeting, which is turning out to be very interesting, and again to the sponsors. I'll be talking today about supplementation with 3 different types of macular carotenoid formulations, and that's becoming particularly relevant. But before I start, I'm just going to give my disclosure slide. So basically, as you can see, there's no nutraceutical company in the world which hasn't in some way supported our research group or our research, or me personally for attending meetings, etc. But in every case, we maintain scientific and editorial control. Now, up until today, this is the first time I've given a talk where I can say the protective effect, because it's no longer the putative protective effect. There is a protective effect of macular pigment for age-related macular degeneration, and it's attributable to at least one of 2 mechanisms, either blue light filtering and therefore attenuation of oxidative damage, which is in part caused by blue light exposure, or its antioxidant effects. In order to contextualize my talks, I will very briefly discuss 2 recently randomized controlled trials showing a benefit of supplemental lutein and zeaxanthin in patients with non-advanced age-related macular degeneration in terms of vision or progression of age-related macular degeneration. But the main thrust of my talk is really to acknowledge, right from the outset, that there are 3 carotenoids which make up macular pigment. There is lutein, there is zeaxanthin, and there is mesozeaxanthin, and they do have a specific regional distribution, which is probably not by accident. It probably is by design. We know that lutein is converted to mesozeaxanthin in the retina, and it's unlikely that that happens for no reason, given that there's such a specific regional distribution of the 3 respective carotenoids. And of course, it has been shown by Paul Bernstein's group that the 3 carotenoids, at least in vitro, work better collectively, synergistically. So if you've a test tube and it's a third of each of them, that test tube will have more antioxidant activity than a full test tube of any one of them individually. So it's interesting and it's worth exploring. But before we get into that, let's just very briefly discuss the KARMA study, which was published. I was a principal investigator with Usha Chakravarti, and was published in Ophthalmology last November. Long story short, it was a randomized controlled trial of lutein, zeaxanthin, and co-antioxidants versus placebo. The primary outcome measure was very, very optimistic. It was visual acuity at 1 year, so no surprise that that didn't show a benefit. However, at 3 years, there was a benefit in terms of visual acuity in the treatment group versus the placebo group. Furthermore, serum lutein increases were associated with visual improvement and with a slowing down of progression of age-related macular degeneration. So that lent just some more evidence to the notion that lutein and zeaxanthin and macular pigments, all 3 of them, might be important. But it all came to a head really in May of this year when the AREDS-2 study was published. And when the AREDS-2 study was published, and I'm leaving this to Emily Chu, but I'll just very briefly discuss what it said. The primary outcome did not show a benefit of supplemental lutein and zeaxanthin, and never really could have, because it was on top of another supplement, the AREDS-1 supplement. So it was really looking for an additive rather than a complementary effect. However, the secondary outcomes can be summarized as follows. If you were given lutein and zeaxanthin versus not, you had a 9% reduced risk, which was statistically significant, of going on to get the advanced age-related macular degeneration. But most importantly, if you were in the lowest quintile of dietary intake of lutein and zeaxanthin, that means you had a poor diet, you had a 26% risk reduction of progressing from non-advanced to advanced AMD. Also, and because it was shown in the trial that beta-carotene actually adversely affected serum concentrations of lutein and zeaxanthin, if you were given lutein and zeaxanthin but no beta-carotene versus being given beta-carotene but no lutein and zeaxanthin, you had an 18% risk reduction if you were in the lutein and zeaxanthin and no beta-carotene group of going from early to advanced AMD, and a 26% reduction of profound and catastrophic visual loss. Now, I didn't show the slides. That Emily Chu will be doing that this afternoon. But long story short, as I said, it's no longer, we don't have to open our talks, and I think everybody in this room will agree, we don't have to open our talks and say the putative protective effect of macular pigment for age-related macular degeneration. There is a protective effect of macular pigment for age-related macular degeneration. Now, so I'm going to talk now about our small trial, which we've done and which has just been accepted for publication. It was 3 groups of subjects. All of them had early age-related macular degeneration. That simply means non-advanced. They did not have atrophic or neovascular age-related macular degeneration. That was graded by the University of Wisconsin. There were 3 possible supplements that were given. Supplement 1, high lutein, 20 milligrams with 2 milligrams of zeaxanthin. Supplement 2, the 10-10-2 formula, we call it, 10 milligrams of mesozeaxanthin, 10 milligrams of lutein, and 10 milligrams of 2 milligrams of zeaxanthin, and that's commercially available as MacuShield and as MacuHealth. And group 3, which was 17 milligrams of meso, so that was loads of meso, but very little lutein and zeaxanthin, only 2 milligrams of each. Unlike AREDS, our outcome measures were different, obviously, because it's a small trial and short term. So our outcome measures were macular pigment optical density, visual performance, as opposed to just visual acuity, visual performance, and macular morphology, in other words, AMD grade. Macular pigment was measured using customized heterochromatic flicker photometry. Visual performance, and I'm going to leave this to, there's publications downstairs which will explain how we did it. Visual acuity was using the Logmar chart, and contrast sensitivity was using the functional acuity contrast test at 5 spatial frequencies. We also did microperimetry, glare disability. I'm not reporting them today because they're not fully analyzed. Macular morphology, as in AMD grade, was assessed by the University of Wisconsin in a blind fashion, Ron and Barbara Klein, and they graded them, as I say, in a blind fashion. There were 67 subjects recruited, 52 completing 12 months analysis, 50 completing the 2-year analysis. There is 3-year data, which we have not yet analyzed. The intervention groups were comparable at baseline in terms of all the relevant variables, including baseline macular pigment optical density at each eccentricity, grade of age-related macular degeneration, visual acuity, etc. So here are the results. Macular pigment optical density at 12 months. Now, when you have small numbers like this, you're only, in order to get statistical significance, only large differences will be seen. So in the high lutein group, there was a significant increase at 1.75 degrees eccentricity, but not at the other, at 12 months. At 12 months, the 10-10-2 formula increased macular pigment at all eccentricities, as did the high mesozeaxanthin group. And that's not that counterintuitive, as lutein, the high lutein group, is the dominant carotenoid in the periphery rather than in the center of the macula. At 24 months, though, the lutein group caught up almost and showed a statistically significant increase at almost all eccentricities except for centrally. And these 2 groups here still showed a significant increase at all eccentricities. So it did appear in this small group of AMD patients that if you wanted a rapid rise and a sustained rise in macular pigment optical density, that mesozeaxanthin was of benefit. Again, this lost its significance, the high meso group, so it did appear that the 10-10-2 formula was advantageous in respect of macular pigment augmentation at all eccentricities at 12 and 24 months. Now, contrast sensitivity, letter contrast sensitivity. In the high lutein group at 12 months, this is 12 months, there was a significant increase at 2 spatial frequencies, and these spatial frequencies mean large target sizes. So that's not counterintuitive either, because lutein would be the dominant carotenoid in the peripheral macula. And this is also true for the 10-10-2. And again, not counterintuitive, the high meso group showed improvements in contrast sensitivity that were statistically significant at the higher spatial frequency, the smaller target sizes. This is at 12 months. Okay. Now we look at these 3 groups at 24 months. At 24 months, the high lutein group lost its significance, and I find this quite interesting because people are saying, well, maybe you could just supplement for a year and then go down to a tablet every, every second day or every third day once you reach a plateau. But these data wouldn't support that. The 10-10-2 formula retained its statistically significant improvement in contrast sensitivity at only one spatial frequency, and the high meso group also lost its significant improvement at one spatial frequency. Now, clearly this study is not powered to make meaningful comment on progression of age-related macular degeneration in terms of morphology. Nevertheless, it is worth commenting upon. 79% had no clinically meaningful change. No clinically meaningful change means that from baseline, they did not jump 2 or more grades in either direction. 11% exhibited progression, and 10% exhibited improvement. And that's for the whole group, and it's for the whole group because there was no statistically significant difference between the intervention groups in terms of change in severity scale. And this gets a little bit more interesting on the next slide, because on the next slide, remember those numbers if you can: 79, no change; 11, progression; 10, improvement. Okay? And this is the same data for the whole group combined, and it shows 90% no clinically meaningful change, 4% only exhibiting progression, and 6% exhibiting improvement. Now, if we just go back to the last slide, that meant that, and again, this is consistent with the KARMA study, where there was no improvement in visual acuity until year 3. So it's intuitive that it would take a while for the benefit to be seen. Then, and only 6% exhibiting improvement, and only 4% exhibiting progression, which is much less, and this is all compared with baseline. So this is 2 years compared with baseline. The 12-month data was obviously compared with baseline. Now, so again, there was no change between the intervention groups. Now, what this tells me is very encouraging, because it shows that macular pigment augmentation, regardless of the intervention, appears to be working. Now, no subject progressed to late-stage AMD. Again, statistically, there's no way you could make meaningful comment on that. But it's still worth noting that this was taken from the same population as the KARMA study, southeast of Ireland, all Caucasian, where there was a 12% at 2 years risk of progression to advanced AMD. And that would translate in this group of 50 who were followed for 2 years, 6 progressing, and we got none. It's anecdotal, but it's worth reporting. We have some 36-month data which we have not analyzed, and here's a case graded by the Wisconsin Grading Center of just one large soft druze, and they graded it as grade 4. And 2 years later, the druze had disappeared without, and this is very important, without leaving atrophic changes, because drusen disappearing isn't always a good thing. You only want them to disappear if it leaves an unscathed retina. So again, anecdotal, but it's worth commenting on. Finally, at the 3-year visit, this is 36-month data, we can see macular pigment in 4 subjects, this is final data, is much higher than it was for our population to start with, which was an average down here of 0.2. So in other words, macular pigment augmentation with these formulations is working. It is increasing macular pigment, but it does appear to need sustained supplementation. So the main findings of my study are that macular pigment optical density does increase with the high lutein group, with the 10-10-2 MacuShield MacuHealth formulation, and the mesozeaxanthin group. In this group of patients with early age-related macular degeneration, to have an increase at 12 and at 24 months in a sustained fashion at each eccentricities, the 10-10-2 formula appeared to be best. Contrast sensitivity did improve in these patients with early age-related macular degeneration at various spatial frequencies in each of the 3 treatment groups. Again, to sustain that at 24 months, mesozeaxanthin seemed to confer some advantage. We can't make meaningful comment on macular morphology in this trial, but it does appear there's cause for optimism that with the slowing down of progression, that maybe macular pigment supplementation is going to once again be shown to be advantageous. The strengths of this study are that it did measure macular pigment, and that we didn't ignore one of the 3 macular carotenoids, and that we went beyond visual acuity. The weaknesses are clear. It's a small study with short follow-up. But these weaknesses will be addressed by a study we've just embarked on called the CREST AMD study, which is a much larger sample of patients, double-blind, randomized controlled trial, where we will be comparing the AREDS 2 formula with the AREDS 2 plus 10 milligrams of mesozeaxanthin formula. Before I finish up, I'd just like to acknowledge the contribution of all my co-workers and people who've contributed to this work, including Quadjo, obviously John, and Alan Howard. There's our group photograph, and you've seen these pictures before of our lab. Katie Marr, Rachel Moran, Jim Stack, our statistician, and Sarah O'Regan. Niamh, who you've all met over the last few days. Christine, who's our bookkeeper. Claire, Kate, Jessica, and Sarah. Thank you very much.
Okay. What questions are there? So I have a question for you. You emphasize mesozeaxanthin. I know there's not a lot of data yet, but why do you think mesozeaxanthin would be better than just supplementation with zeaxanthin itself?
That's a good question, and I don't.
Okay.
Because I don't know.
Okay.
But the only way to do that is a head-to-head trial of similar doses.
Yes.
Which I don't know if there's such a formulation at the moment. But to answer the question as a scientist, you would have to give 10 milligrams of meso versus 10 milligrams of zeaxanthin, right, and check their profiles.
Now, are you doing that in some of your other studies?
No.
Or no?
No.
Okay.
The answer is yes. Perhaps I'd like to comment. You know, mesozeaxanthin has been around probably for about 20 years now. You can buy it. The trouble with zeaxanthin is only rather relatively recently you could actually use it for human studies. Now it is available, and I think we are actually doing studies with it, and I think it'd be worthwhile seeing if zeaxanthin is in fact equivalent to MZ in this type of work. One thing I say is the price of MZ is in fact much cheaper than that of zeaxanthin because of the production costs. It's so easy to make mesozeaxanthin. All you have to do is take lutein and heat it with potassium hydroxide. The other way, you have to sort of, it's more complicated technology, which leads to greater expense.
Okay. Yes.
I was wondering going forward in the
Hold on a
study,
second. Here.
whether you're going to be using the Maculogics AdaptDX device. I have a couple of slides to show on that later this afternoon, which is shown to have much more sensitivity and specificity than contrast sensitivity. Although contrast sensitivity is very nice for describing the visual system, it's clouded by neurodegenerative disease, it's clouded by cataract and glaucoma. It's a very non-specific visual function test and of lower sensitivity and specificity than the Maculogics AdaptDX, which has been approved for dark adaptometry and probably will be approved for specifically AMD diagnosis.
I'm going to let the gentleman beside you answer that.
The answer is no. The methodology has been published in terms of what we plan to do, and contrast sensitivity is the primary measure in that. So the quick answer is no.
The accumulation of mesozeaxanthin and also the dietary zeaxanthin is obviously through the circulatory system. Do you know of any study, perhaps including yours, that shows the relative bioavailability of meso versus the dietary zeaxanthin, or any interaction between the two?
We published a study, it was in the British Journal of Nutrition last year, and Katie, you may want to come in on this here. Rachel, if you want to bring the microphone. Long story short, we supplemented, and Katie knows the details better than I do, but we supplemented with the same formulation in the same group of patients and looked at serum bioavailability. And that was the study where we inadvertently found mesozeaxanthin in the serum of people supplemented with high lutein. And that prompted us to go back and look at that high lutein formulation, I think it was ultra lutein, where it did have a small degree of mesozeaxanthin, but I'm digressing. Long story short, best serum bioavailability was with the 10-10-2 MacuShield, MacuHealth formulation. Do you want to come in on that, Katie?
Yeah, no, the group 2 definitely performed better in terms of serum response in that paper. What we did notice with the group 3 formulation, which if you looked at Professor Beatty's slides, was a high meso supplement with 17 milligrams of mesozeaxanthin, 3 of lutein and 2 of zeaxanthin. The zeaxanthin and lutein were a little bit muted in response in that supplement, as you'd expect. The mesozeaxanthin and zeaxanthin structures are so similar that they're bound to compete because they go into the same areas. So I think if you had a supplement like that, you mute the zeaxanthin levels because there's too much competition between mesozeaxanthin and zeaxanthin. But as Professor Beatty said, you do need to have a study where you can match them head to head with a similar dose as well, and potentially a combination to see if you get a similar response in serum.
Try? Oh.
So 4% improved in macular morphology after 2 years, is that right?
Yeah.
I'm just interested in your thoughts. What's the mechanism that makes drusen disappear? What do you think lutein would do that?
I suppose if a drusen is to disappear, leaving an unscathed retina, it can only disappear out the back. So it must go through Bruch's membrane, and the retinal pigment epithelium must be stimulated to remove those waste products that are drusen. And why would macular pigment supplements help that is really your question. And possibly the antioxidant effect, but it shouldn't really. So I don't really have a theory. Paul, maybe you have a theory on that. Why would the drusen disappear?
It's a very hard thing to say. Drusen do come and go. Sometimes they leave atrophic changes behind, some they don't. I would say that the example that you showed was pretty unusual to see one large drusen, essentially a normal looking retina there. So it would be very interesting to look at the OCT on that patient. I don't know if that was available on that patient to see what was going on.
And the other eye?
Yeah, and the fellow eye.
I mean, we have done a lot of studies now with polarization-sensitive OCT, which appears to be the best method to quantify drusen. And it is not a rare finding that drusen disappear. This can even be in pretty short periods. Generally, it is the case, the less drusen you have, the more likely are they to disappear. The more advanced AMD, the less you see drusen disappear. But we did a study in over 3 months only, and that we saw a reduction in the drusen volume with polarization-sensitive OCT. You can measure drusen volume and treat drusen area as well. We saw a reduction in drusen volume or drusen area in more than 10% of the patients over 3 months.
Yeah.
What is the mechanism, I think, is pretty unknown.
Yeah, you just have to be very careful about presenting anecdotal
not with
results.
lutein supplementation, just the natural course.
Yeah, you have to just be very careful about presenting anecdotal reports of drusen coming and going. You need to do a larger study. Yes.
And Paul, you made the point 2 years ago to be careful with it and look at visual function, because as we've said, drusen disappearing is not always a good thing, but in these cases, visual function was improved, so albeit small, it's interesting.